So this year's ASCO meeting, while focused on precision medicine and thinking about molecular profiling and deciding how best to treat smaller and smaller groups of patients, we saw some big impact stories as well that came out. So personalized medicine at the other end of the spectrum, women who've had their breast cancer resected and now are deciding whether to receive adjuvant therapy. Joe Sperano presented on behalf of a number of investigators the results of the TAILORx study, a trial that entailed thousands of women with ER-positive breast cancer undergoing the Oncotype DX molecular profile. This 21 gene recurrence score, in fact, showed that patients who had an intermediate risk score between 11 and 25, in fact, do not need to receive chemotherapy. That is a huge advance in terms of better understanding the risk factors around these patients. They'll still continue to receive hormonal therapy. There remains a group of patients who need chemotherapy, but being able to avoid what seems to be an ever-growing younger population of patients from having the long-term effects of chemotherapy, very, very important. Also on the breast cancer front, Trastuzumab. The use of Trastuzumab in breast cancer has been one of the great stories over the last 20 years. Talking about taking a disease that was uniformly fatal and now having those patients with greater than 90% long-term survival. That being said, a year's worth of therapy is a long time in the adjuvant setting. Results from this ASCO meeting showed, in fact, that 6 months of Trastuzumab is as good as 12 months of Trastuzumab. That'll be interesting to see how that uptake goes. One would think we might be driven by the data, but it's fairly well tolerated. The hard to change habits, doctors will begin to think about patients that might be at greater risk to try to continue on with those types of therapies. So again, that'll be an evolving story, but this duration question, one of the ways to handle costs to me is going to be how long do we have to give these therapies. I think the other way to help handle costs, which was addressed in several sessions, is treating the patients who need the therapy. The immunotherapies have been a wonderful addition. The fact is, in most disease settings, it's a specific group of patients that benefit, and we need to really define that group and not spend the time, money, or waste the efforts on patients who are unlikely to benefit. So moving on to immunotherapy in non-small cell lung cancer, still one of the most high volume diseases, still one of the cancers where we have too much fatality. The use of Pembrolizumab in the first line setting versus chemotherapy was a positive result presented at the plenary session. Exciting news. We're going to still continue to see Pembrolizumab with chemotherapy. We're going to continue to see a variety of combinations of those sorts of approaches, but the idea that the immunotherapies are going to change how patients do with non-small cell lung cancer, a critically important result.